Hi, welcome. We'll talk about the surgical anatomy of esophagus and few fancy named diverticle of the upper esophagus. So basically, the esophagus is extending from the lower border of cricoid, which is C6, up to T11, and the approximate length is 25 centimeter, and it has many anatomical specialties which we cannot see in other organs. So the first thing is, unlike many of the organs in GIT, it is not covered by a serosa, but like the esophagus, we also have the rectum, which doesn't have a serosa, and it has two muscles. The proximal has a striated or skeletal muscles, and the distal has smooth muscles. Okay, and it has two types of epithelium. That is the proximal most we have the squamous, stratified squamous non-keratinizing epithelium, and in distal we have the columnar epithelium, and we also have segmental blood supply. So we'll divide it into three segments. The upper part gets its blood supply from the inferior thyroid artery, middle part direct branches from the aorta, and the lower part from the inferior phrenic artery. And also same goes with the venous supply, where some part is drained by the azygos vein and other parts are drained by the left gastric vein. And main thing is it has a longitudinal lymphatics, which is very dangerous. I tell you that. So this longitudinal lymphatics plays a very important role in metastasis. Suppose this is the esophagus, and here we have a esophageal carcinoma here. And because the lymphatics are present in the submucosa, it can easily metastasis proximally, and it can also easily metastasis distally, even without the tumor depth being so great. So that's what the problem with the lymphatics being arranged longitudinally and especially in the submucosal plane is all about. And what are the lymph nodes the esophagus drains into is the paraesophageal, periesophageal, and the lateral esophageal lymph nodes. What is the significance? That's why during esophagectomy we'll do three-field lymphadenectomy so that we don't spare any lymph node to avoid the recurrence. What is the nerve supply here? The esophagus receives both sympathetic and parasympathetic. Sympathetic from the T5 to T9 spinal segments, parasympathetic principally from the vagus. And that's why sympathetics carry the pain, and any esophageal pain sensations are carried to the epigastrium through the sympathetic nerve supply. Now, what are the parts I told you now? Upper, middle, and lower. So it's actually termed as cervical, thoracic, and abdominal. So this is the part totally 25 centimeter. Thoracic part constitutes for 20 centimeter, cervical for 4, abdominal for 1 to 2 centimeter. Now, is this esophageal tube a straight tube? Like if you're looking from the anteroposterior direction, is it like this, or is it something like this? Some bends are there. So actually, it's not like this. Some bends are there. For that, we'll remember, like if you're going to march forward, what do you say? We say left, right, left, right. This is what we say. So that's how the esophagus also follows. So the cervical esophagus is in the leftward direction, right? Okay, and the thoracic is in the rightward direction, and the abdominal esophagus is again going towards left side. So this is the parts and the direction in which they are slightly tilted towards. Okay. So what are the we told, right? If this is the anteroposterior thing, this is not the actual view. We have something like this. Okay, something like this. So is this a full hollow tube, or is there any constrictions over there? We do have constrictions, and again anatomically they explain 4 constrictions, and surgically we have 3 constrictions. So anatomy people will first see anatomically how they are divided. So this is how the constrictions I explained. We take a fixed point as the upper incisor teeth. Why not the lower incisor teeth? Because the mandible is always moving, right? That's why the upper incisor teeth is fixed. So from that, the ratio is 6 is to 9 is to, it's just a mnemonic, 11 is to 15. Okay, we don't have 13 here. So 6 and we don't have 7, 6 is 9, and again 11 is to 15. All these are inches. So first constriction is where the cricopharyngeus muscle comes here. And second constriction is where the arc of aorta crosses the esophagus. And third constriction is where the left main bronchus goes into the lungs. and fourth constriction is where the diaphragm we have. So what is this view? So we are looking from the anterior into the posterior direction. So all these constrictions are present anatomically. So what happened was surgery for surgical anatomical purpose. This was very distant, and this was also distant. So surgery people said only three constrictions are there. So they clubbed this together. So finally, what was the result was for surgery? This is the result. So the cricopharyngeal junction, that is the first constriction, which is 15 centimeter. Next, we have the aortic and bronchial constriction. They clubbed it together, which is 25 centimeter. And the addition also comes very beautifully for us. 15 plus 25 will get 40 centimeter, which is the next constriction we have, which is the diaphragmatic or sphincter constriction. Again from the incisor. Right. So yeah, this is the upper esophageal sphincter or the cervical constriction. So significance is 15 centimeter. It is the narrowest part in the GIT. That's why more prone for foreign body, like a foreign body will get stuck there. So that's the significance of this region. And next we have the bronchoaortic constriction. Again, they clubbed both of them. It's from 25 centimeter, and diaphragmatic we have 40 centimeter. So if this is diaphragmatic or lower esophageal sphincter, so that's a question. So if we ask that this lower esophageal sphincter itself is not a sphincter, so let's come to that. So we differentiate between the upper esophageal sphincter and the lower esophageal sphincter. So upper esophageal sphincter, as you all know, we have the cricopharyngeal muscle here. This is constricting, and that is what we call it as the upper esophageal sphincter. That is a structural sphincter. Okay. But now, what about the lower esophageal sphincter? Is it a structural sphincter? Is there a muscle? Definitely, like it is assigned for this sphincteric action. The answer is no. It is actually a high pressure zone. Okay, that's what you're. It's like a functional sphincter. Now, this high pressure zone is actually because of two muscles, which is because of the intrinsic muscles of esophagus and the crura of diaphragm. Now, how do I say it's because of two muscles and not only because of the intrinsic muscles? That's why we'll do an investigation to find out that. So that investigation is nothing but high resolution manometry or simply manometry. Manometry means we monitor the pressure changes. So this is the normal high resolution manometry of the esophagus for you, me, and you, right? So with this coming down, what happens is this is the upper esophageal sphincter. This is the lower esophageal sphincter. LOS or ALES, whatever it is, LOS. This is the UOS. So what is happening is we are descending, right? This is the descending from this is the superior part, and this is the inferior part. So we are descending down, and these are the levels. These red regions are where the more constriction or more pressure is there. So what happens is here some person is swallowed. So what I told is the upper esophageal sphincter. What happened? There's constant tension. Once they have swallowed, what happens? This tension is gone, and again the tension follows over here and remains constant. Now then, what is all this? These are all the remaining tube constrictions. So that is what is being presented in a graphical manner here. So these tube constrictions will be there no? Once the food is going down. The primary, secondary peristalsis, all these are recorded here. And once the food reaches the lower esophageal sphincter, that's what we will get over here. So we are getting lower esophageal sphincter rate, like pressure zones over here. So this is the normal person. Now again we have not answered why the lower esophageal sphincter is because of two muscles, namely the crura of diaphragm and also the intrinsic muscles. So for that we need to go to a pathology known as the hiatus hernia. What happens in hiatus hernia? So this is what is the hiatus hernia will look like. So this is the diaphragm over here. We have the esophagus. Normally it should be something like this, and the gas, the stomach should come like this. What happens? This doesn't occur. What happens is this is the diaphragm. We have the esophagus over here. We have one pouch here, nothing but the stomach fundus has gone there, and again we have something like this, and rest of the stomach is going here. So this portion is where there is a herniation. what happened is, this is the esophagus. Earlier, this was the intrinsic muscle which was contracting in the esophagus. And where was the crura? The crura is in the same place now. Now, if I do a manometry, there will be two levels of pressure zones. One because of the crura and one because of the intrinsic muscle. And that's how they discovered this high pressure zone was not only because of the intrinsic muscle, it was also because of the crura. Now see here, we have the lower esophageal sphincter here, which is the intrinsic muscle, and we also have diaphragm over here. So both now in high dysautonomia we have two pressure zones here one and here one. But here we have seen them, but together they form a red zone. So that is the difference between upper esophageal sphincter and the lower esophageal sphincter. In short, the upper esophageal sphincter is actually a structural, the lower esophageal sphincter is just a high pressure zone. Coming to some fancy terms, which is the collar of Helvetius. Okay, what is the collar of Helvetius? It's actually normally we have the outer longitudinal in esophagus and the inner circular muscles. Right. Usually this is what is present here in GIT. Outer longitudinal and inner circular muscles. In stomach alone, we have extra innermost oblique. So you see here, this is the outer longitudinal, inner circular muscles of the stomach here, and the innermost we are having some oblique muscles. Now, what is the origin of this in oblique muscles is nothing but they are also derived from like their continuation of circular muscles of esophagus. The point where the circular muscles of esophagus will convert into the oblique muscles of the stomach. That point is what is known as collar of Helvetius. Just an anatomical question, nothing related to surgery. Okay, not much. Okay. So this is the collar of Helvetius, a fancy term. Now, I told you what is the lower esophageal sphincter, but what is the esophageogastric junction? So for that, if it's an easy question, it would be a one-line answer. But for that, we have four theories, out of which only two is useful. So the first theory is anatomical. Anatomical is where the tubular esophagus is turned into a saccular stomach. Yeah, it's understandable, right? It's a tubular esophagus turning into a saccular stomach. Okay, this is the anatomical explanation. Now, next is histological. You take a biopsy in the this part, and again on this part. So here you'll see columnar epithelium. Here you'll see sideways column non-keratinized. What will you see here? You'll see both. So that junction where squamous epithelium turns into columnar epithelium, histologically that was said as esophageal gastric junction or gastroesophageal junction. Now this is the histology of our esophagus, especially the upper part, because we are having sideways cones non-keratinizing epithelium. Now coming to the two important which we'll use in endoscopy is, first thing is, rest of the world agreed with this and the Japanese people told this. Second, so what the other people said was, the endoscopically the gastroesophageal junction is where the upper borders or where the upper folds of the gastric folds end. So you see here, this is the top of the gastric fold, right? This again, this is the top. This is the top. This is the top of gastric fold. Like this, if you continue for every gastric fold, will form a circle. So this is what they call it as gastroesophageal junction. Okay. Now you will be able to understand, I guess. Now, what did Japan say? Japan said that like you see here itself you can see some palisading vessels here. I'll remove it. You can see here, palisading vessels. So Japanese people said that the distal end of esophagus is where the palisading vessels are found. So you see the palisading vessels are found here. Near this is what the gastroesophageal junction is. So that's what the Japanese theory was. And so this is the four theories of where the gastroesophageal junction is. So that's it. And that's again a theory part. Now coming to the fancy terms where the diverticulars actually occur. Okay, we basically have three diverticula. Okay, out of which the most known for us is the Zenker's diverticula, and the triangle is Killian's triangle. Now everything we'll explain with this image. So first thing is Killian's triangle through which the Zenker's diverticular. So what is this view actually? We are looking at from the posterior view. Okay, then what is the anterior? We don't have the anterior image here. This is the lateral view. Okay, lateral view. So from this direction, if I see here, this image is what I will get here. Okay, so let's understand the posterior thing here. Like, so this is the cricopharyngeus muscle which produces a constriction of the esophagus. If you remember, it is dash centimeter from the upper incisor, oh, no, 15 centimeter, right? So this is 15 centimeters from the upper incisor tooth. So this is the cricopharyngeus muscle we know about. Now above that we have the inferior constrictor muscle. Okay, this is one of the constrictors of the pharynx. So we have the inferior constrictor muscle, but this muscle does leave some space here, and I'm sure you recognize that this is the triangular space. This triangular space is nothing but the Killian's triangle, and this is a weak zone. Okay, this zone is where the diverticular occur, and if diverticular occurs here, we call it as the Zenker's diverticular. And this is a separate video altogether for it. Its management, its investigations. It's a separate video which I will make in the future. Right. Now, above the cricopharyngeus muscle, because of the inferior constrictors, we have a upright triangle here. But below the cricopharyngeus, we also have a triangle, but it is an ulta triangle or something, which is an inverted triangle. But now, the base is common for both the triangles, which is the cricopharyngeus muscle. But for this triangle, which is known as Lehman's triangle, what is the sides? Okay, sides which is leading to the apex. For this, it is the longitudinal fibers. See, in the esophagus, we have the circular fibers here, and the longitudinal fibers is what is running over here. Outer longitudinal, inner circular. I told you, no. So the longitudinal fibers would go sideways the upper esophagus. That's why they are leaving a space over here, forming a Lehman's triangle. So this is also a potential space for diverticulum to form. And what is this name? It is nothing but a Lehman's diverticulum. Now finally, on the lateral view, so this is the thyroid cartilage. Okay, this is the cricoid cartilage. It should be a full cartilage, something like this, because muscles we are not able to see. And we also have the another triangle. For this, the cricopharyngeus muscle itself is responsible. It is bounded by the oblique fibers. This is the oblique fibers and the transverse fibers of the cricopharyngeus muscle. So the oblique fibers and the transverse fibers of the cricopharyngeus muscle. And if diverticulum occurs here, it's known as Killian-Jensen diverticulum. Okay. So with this, the anatomy and a few diverticulum is over. And finally, thank you so much for watching.